This week on the BackTable Podcast.
You know, I mean, from the urology perspective, and maybe it's because I have a guilty conscience, but you know, I mean, we rely on IR for a lot of different things, and I think having that collaborative relationship is really important. And you know, PAE is just a small piece of that, right? But at the end of the day, it's what's best for the patient, and that's the goal.
Hello, everyone, and welcome to the BackTable Podcast, your source for all things IR and endovascular. You can find all previous episodes of our podcast on iTunes, Spotify, and on BackTable.com. This is Michael Barraza returning as your host. I'm recording from Baton Rouge, Louisiana. Before we get into today's topic, a quick word from our sponsor.
Medtronic offers a comprehensive portfolio of products for the embolization of the peripheral vasculature. Learn more about the MVP microvascular plug system and Concerto detachable coil system at medtronic.com/embolization.
Today, we're going to be talking about building a PAE practice in collaboration with urology. Our guests for today are well-known champions of this approach, having together helped establish Chapel Hill as one of the premier centers for this procedure in the U.S. It's an honor to welcome Dr. Matt Raynor from the Department of Urology at UNC and Dr. Ari Isaacson from the Department of Vascular and Interventional Radiology. Thank you both for taking the time to share your experience, especially Matt, who has to be getting sick of talking about PAE with interventional radiologists he doesn't know. Thank you.
Thanks, Mike.
Thank you, Mike. Glad to be here.
Thank you. And, you know,
he's lying, by the way.
No, but yeah. I suppose it's one of the consequences of success, and people want to know how you did it. And fortunately, since, you know, so much of the data supporting PAE has come out of Chapel Hill, we can really glean a lot about your system from the literature and the other educational resources you've given us. In particular, Stream, which has, you know, really evolved from Stream PAE to PAE Stream. I think it was Streamsk recently, and now it's
Stream
just
SK. Stream SK.
It's really just an entire lifestyle now, I think. But really, the conference itself is easily the most useful and instructive meeting I've ever attended. And I've also really enjoyed the Stream Happy Hour Zoom meetings, which is where I stole the idea for today's podcast. What can we expect from the Stream Dream Team in the near future? You like that?
That's a good. I like that. That's a good question. Well, you know, Sunny Bagla and I are just we're just waiting for when we can do a live meeting again, because as you know, as having attended previously, that's our thing. I mean, we really, our goal is to provide a live experience that is entertaining and is educational. And I don't think really the virtual format is really where we shine. I mean, the happy hours are nice because they're short and we get a bunch of guys together and it's kind of informal and we talk about a topic, which seems to work out. But as far as a more formal virtual format, we're not going to go there with Stream. So we'll just kind of hang on and wait till we got a vaccine and then get back into live stream again.
I'm going to disagree with you about the live format because I've seen your rap videos and they're extraordinary. But no, it's an incredible conference. It's more than a conference. I mean, it's the only meeting I've been to where I walked in to learn something and walked out ready to, you know, kind of take a procedure on my own. And so I really look forward to that coming back as well. I was registered for this year and, you know, and sad, and, you know, obviously it was appropriate that it got canceled. Another great resource for learning PAE is, of course, the book, The Two, you published along with Sunny and Dr. Yu. I own it, highly recommend it to all of our listeners seeking a more comprehensive review of the management of symptomatic BPH. It's cleverly titled Prostatic Artery Embolization.
We had to really work hard on that one. We thought about that for a while. Yeah.
You can get it on Amazon. You can get it on Springer.com. I think only the Springer one gives you online access for the book, was really helpful for the anatomy figures. But Matt, I found your chapter on like the various surgical options for BPH, particularly insightful. It really helped me navigating discussions with my own urology colleagues to identify, you know, where I could offer something of value. You guys did a great job with that book.
Yeah, I think it was also geared to at least provide some talking points for radiologists so they understand what procedures are out there, understand the pros and cons of those procedures. And then, you know, these patients are also very savvy and well educated for the most part. And so that they know about these procedures as well. So just to understand all of the options that are available.
Yeah. The third most important educational resource for PAE that I can think of is pretty obvious, and it's the podcast that I recorded with Ari and Sunny, which was, I mean, as I said earlier, it's almost 3 years ago. It's a big surprise. I thought it was a lot more recent, you know, and I guess time flies when you're stuck in a global pandemic. But PAE has obviously made some headway on the growth curve since then, but I think a lot of people, myself included, struggle to see that same growth locally. So it's a great opportunity to learn from people who have done this successfully. And I'm also fortunate to have had the opportunity to see your model in person. Yeah, as I told Matt, Ari graciously hosted me for a day a few years ago.
Man, that was a while ago.
What was that?
Like 4 years ago?
Yeah, it was about 4 years ago. I was, just a young, dramatically handsome and talented young attending right out of training.
That was my first thought as soon as I saw you.
But I got to see what you guys put together, and I modeled my own approach, like essentially exactly like your own. And so this is a good opportunity for me. So I think what would be really helpful to start with is have you guys just, take us through the story of building this and then show us what it's like, what it looks like there. I mean, it seems like both urology and interventional radiology departments were involved in this from the beginning. Ari, why did you decide to get, Matt's help with doing this in the initial trial rather than just doing this on your own?
Yeah, so I started this when I was pretty fresh out of fellowship. It was my first year out. I wanted to get involved in researching a procedure that I thought potentially could take off and become something that we do regularly. And the funny story was it was between this and renal denervation. And I wanted to do renal denervation, but cardiology had already taken it. So I was like, oh man, I got to do the prostate. I don't know anything about prostate. So I decided I was going to try to do an IDE trial. And I knew it was important, especially when you go through the IDE process and you go to the FDA, they're going to want to know that you have a co-investigator from urology. So it wasn't like I chose to do that. That was necessary. But I was fortunate. I forget. I think I knew Matt because I was a resident and fellow, and I had kind of interacted with him at times. And he seemed like a nice guy. And I went up to him at one point and I just said, would you be interested in, being a co-investigator on this trial if I put this together? And he was very gracious and said he was open to it. And that's kind of how it started. I don't know, Matt, what was your point of view? Maybe it was completely different.
No, it was pretty similar. I think, for years we've been fortunate to have a collaborative relationship with IR at UNC, and our clinics are literally right across the hall from each other. So proximity helps. And, we've always been about how can we better evaluate new technologies and sort of stay at the forefront of evaluating these things. And it just, honestly, it wasn't too much work for us on our part.
That was one of my tricks. I was like, I'm not going to do anything. I'll just ask him if he'll put his name on it and do a few things here and there. And that worked out.
Do some cystos, and that was pretty much it. And it worked out, and it took off from there. And we've been, it's been 6 or 7 years now.
Yep.
So it's been a great relationship.
Wow. I'm curious how your model for offering this changed. Like, how did it evolve from there? What were some of the changes, and how did the two departments basically maintain their own interest in this? So that both parties are getting to contribute to patient care in the way they wanted to?
Well, I'll say from the urology point of view, there was a little bit of angst up front from some of my department partners.
Hey, Max, can I tell a quick story here?
Yeah, of course.
Maybe this is what you're referring to. I don't know. I think our very first case we did, we kind of
read my mind.
We like took an inpatient hostage. No, we had an inpatient who was an elderly, kind of demented man, and his son was there, who was his power of attorney, or was signing all the forms for him and making the decisions. And we said to his son, this man was in urinary retention and had a Foley, and we said to him, well, we have this brand new procedure that we're just starting out trying. And we potentially could get him so that he doesn't need to urinate anymore, or he doesn't need a Foley to urinate anymore. And so the son was like, well, the Foley's a big pain in the butt for him at his nursing home where he's at. And he's like, if you think you can do that, then yeah, you have my permission to do it. So we got him and we brought him down and we did the procedure on him. And I don't know, maybe we should do this, like take turns here, Matt. So we did that. And then what happened after that on your guys' end, Matt?
Well, I'll just say that a member of our department found out about it. It was not thrilled to hear what had happened. And it basically devolved from there. It was not a pretty scene. But Fast forward. And
so I'll tell you what happened next on my end. So I get an email or something from our chair saying that someone from urology has found out we did this and was not happy about it, and our chair was kind of giving me that feedback. And fortunately, I did this with my division chief at the time, so it wasn't just me standing on my own. But from at that point, we realized maybe we overstepped our bounds a little bit on this one. But we had to get the first case done. You always have to get your first case.
Totally.
So the irony or the interesting part to me is, we're going to fast forward now. What were you going to say, Matt? Fast forward to what?
No, I was going to say fast forward to now, and we have a procedure that we know works. And to be honest, this is something that I say at all these meetings, is that everybody's worried about competition, but the truth is it's actually increased our BPH business, this collaboration. So it's been fruitful for both sides.
Yeah, so what I was going to say was fast forward to just, I don't know, maybe about a year ago, when the procedure link was on the urology website adjacent to the picture of the person who was very unhappy about it.
Right.
When we first did it 7 years ago. So like Matt said, we're fortunate. I don't know that was the best way to go about getting the first case, but I was just acting under my division chief's advice. So I can't take any real credit for it, but you got to get your first case done somehow. And I think, we did that the first time, and then we said, we can do this, we can do a trial. And so then we kind of went about it the right way, which is, putting a trial together and doing it with all the right regulatory things in place. But like Matt said, a lot of people have come from outside of our catchment and UNC to come get this procedure. And a lot of them have ended up becoming patients of UNC urology who weren't previously. And so it has benefited both of us. Yep.
So what does it look like now when you guys do this? I mean, for an average patient to come through, what's the process like?
Yeah. So I would say at this point, I think it's I would say I get about 60% of patients are referred from UNC urology, and the other 40 are self-referred from outside. And so it's great. I mean, this is what I always dreamed about, was to have patients coming to me from UNC urology who have already had the workup done for BPH and have all the notes in our medical record system. Because previously, I'm having to get medical records from all over the country. But it's great just to have them there and know that they've been worked up and they're ready to have a procedure done. And so for those patients, they come and they see me for the PAE. I see them in clinic prior to doing the case. And then their next follow-up is with Matt back in urology 6 weeks or so after the procedure. And so that works out really well. And there's several members of the urology department now who have sent patients over for this procedure.
That's cool. I mean, what I really liked about your system is that I think it still is ensuring that these patients are getting the best care. I mean, anybody who's offering this procedure from our end should be studying it and understanding the pathophysiology and medical management and everything else. But, the urologists are the ones who should be managing a lot of BPH care. I don't have any business really doing uroflow in my office. I know some people are. For me, it's not the right fit. I just feel more comfortable introducing this in collaboration because, we're working with the experts. There's not another specialty that understands this disease better. Do you agree?
Yeah, absolutely. I mean, that's always been my mentality, is I'm not here to be the urologist. I'm just here to do this procedure. Now, I've had, some people in IR will kind of take a stance against that kind of statement where they say, well, you need to have more ownership of your patient. But, to me, that's not best for the patient. What's best for the patient is to go to urology to be worked up for BPH and then to be followed. And I think the reason that it's important for me to send the patient back to urology afterwards is, what if PAE doesn't work for them? I quote an efficacy rate of about 80%, right? So 20%, and I'm a little conservative there, but I think, I'd rather be conservative than overstate the efficacy. So, if 20% of people at 4 months, say, are still having urinary symptoms where they want to have another procedure done, well, who should they talk to about that? Should they talk to me, or should they talk to a urologist who does those procedures? So that's kind of the motivation. The other thing is that, like you said, they have the Uroflow machine. They could do the cysto if need be. They have all the stuff. So For me, the best patient care is for urology to evaluate them before I see them and then to evaluate them afterwards.
Yeah. Matt, has this system worked well for you? Any particular challenges or anything that, that you guys have run into trouble with?
No, we've not run into any trouble at all. I would say that at the beginning of this experience, it's interesting to sort of see what type of patient came through. A lot of patients who did their own research, they can be particularly challenging, I'll say, in some respects. But now that I think, PAE has become much more part of the sort of normal lingo with patients that we talk about BPH treatment options, at least at UNC. And it's almost second nature. I treat a lot of kidney cancer as well. And it's almost like a discussion that I would give with a patient for cryoablation. Same thing.
Sure.
That this is a procedure in collaboration with IR that is an option. So let's talk about it.
So that, I think, Ari, you said probably 60% of your patients are coming from referrals from the urology department. Matt, are most of those patients who are coming from your office the ones that come in like, this is what I want to have, this is the procedure that I want? Are there specific patients that, that you recommend this for?
Yeah, that's a good question. I think, initially, no, it was actually men who were seeking out PAE. And then, Ari was just sending them to me just to, I don't know, play nice maybe. But those men were specifically seeking out PAE because of the, lack of sexual side effects and all that goes with PAE. But now it's, I talk about PAE with basically any patient who is considering an intervention for BPH.
Okay.
And yes, there are specific patients that come to mind, or a specific type of patient, those men who may be on anticoagulation, and maybe it's a little riskier for them to stop the anticoagulation for a procedure, especially those men with large prostates, 100 grams or greater, that we're talking more about a more challenging holmium laser enucleation procedure or simple prostatectomy. Then definitely PAE is in the ballpark for those patients.
And I can't remember who brought it up. It may have even been you on the Zoom conference that, for some of these patients with a massive, like enormous prostate, the PAE, we may be, shrinking them down enough to improve symptoms, but we may also be shrinking them down enough so that they are finally small enough to get a TURP. I mean, do you see that frequently?
So interestingly, we haven't seen it frequently where these men with very large prostates have a PAE and then, progress to needing something else done. Yes, it does happen. I think I saw one patient a week ago that was like that. But honestly, for the most part, when I see them 3 months later or 6 weeks later, they're doing really well. And, I think there are still some question marks maybe about the duration of the effect.
Mm-hmm.
But, we've got patients out now over 5 years who have been doing fine. So I think time will tell with that.
So let's just shift gears a little bit and talk about, things that we could do, basically advice you could give to people trying to build a program from scratch. One of the first questions I was going to ask is why do it in collaboration? But I think we have kind of gone through that. I mean, I think I've made my piece on that and you guys have as well. So I'm now doing it myself for the second time. I had some mistakes that I made the first time I did it in my first job. And I think one of my failures was in just directing this, for one doctor at a time, but also just kind of pitching this as something that could work for anybody. In terms of making the pitch to urology, how would you guys recommend doing it? Is this something that you would pitch to a whole practice or just to individual providers?
So I would say, I think it kind of depends, on the group that you're talking to, but I would target the, the folks that do a lot of BPH at a practice. So again, you're talking about if you work in private practice and you're going to other private practices, or if you're at an academic center and you want to get your own urology group more involved. But I would seek out the guys who do a lot of BPH. And the way I pitch this is that here's this procedure. It's not going to be the right procedure for everyone. In fact, it's probably only right for a minority of the patients that you see, but it definitely is right for some of them. And it has some advantages, like Matt was saying. You're likely to get in less trouble trying to do bigger prostates with people that are on anticoagulation, because if whatever procedure you do, you're probably going to end up with more hemorrhaging than you'd like, and maybe even transfusion and maybe even prolonged hospital stay. So I mean, this procedure has some benefits. And so I would pitch it like that. This procedure fits in a certain slot in the algorithm for the treatment of BPH. And I'd like to be able to treat those patients. And I think when you think about it, from a patient point of view and from best patient care, it makes sense. Granted, we still have the little issue of the AUA guidelines, but I think, I think
I knew that was coming up.
Yeah. But I think you can, I think, I'm going to say talk around that, but I think you can justify it even despite the guidelines. So I think to answer your question, I would either go to an individual at a time who does BPH, or try to get several people in a room over a lunch period where, you bring them some food and show them a few slides and then just talk about what the procedure is. But I think the most important thing, and you kind of mentioned it, Mike, is not to say this is the new, this is going to take over for everything else. This is going to take over for Resume and for Urolift and for TERP and all. But to say that this is a great procedure for a minority of patients that you're going to see, right. And I'd love for you to send them to me to do it.
That's what I've done the second time is say, this is great for patients who are bleeding, patients on anticoagulants, giant prostates. But I actually have run into trouble, with the AUA thing. I told Aaron, I hadn't decided if I was going to bring that up or not, because, I've gotten a urologist to kindly give us his time and join us. I don't want to make this any kind of bashing session. But, one of the first people I talked to today, I mean,
Matt's used to it, by the way. I mean, we've done this so many times now.
I know. But I've talked about it with him. But, one of the first urologists I talked to here, I brought it up. I was like, look, just the giant prostates, the ones that you're having trouble with, I would love to help. And it's like, well, the AUA guidelines don't really support it much. And so for now, I'm going to kind of hold off. And I've kind of struggled with the best way to approach that. What do you guys think is the best way to manage that? I mean, is it wait? I mean,
Matt, why don't you comment on that?
Yeah. That's a tough one because, my retort to that is the guidelines are just that. They're just guidelines. They are not practiced standards, I would say. Yeah. And, when we get particular about these guidelines, they are evaluating data from before September of 2019. And so, a couple of the important papers really supporting PAE weren't included. Right. And I think with time, those guidelines will change. I mean, it took years and years for hematuria guidelines to change. It's just the way the AUA works with how they evaluate data. So, in the strictest sense, I think if a urologist is really stating, look, I'm not going to do it if the AUA guidelines don't support it.
I think it's fair. I don't fault him on that at all. But really, in general, I mean, I think one of the hardest things that I've dealt with in trying to do this is finding the right way to get my urology colleagues to buy into this, and I think I could do a better job at establishing this as it's not so much competition, but it's a way to provide something to more challenging patients. Either you have any input on that in terms of really how to get both departments to buy in?
Hey, Mike, let me step back for 1 sec before I answer that, because I would. This is what I would recommend you do for the urologist who gave you kind of the guidelines answer. I would get the 2 papers that were not included on the guidelines or weren't reviewed for this current guidelines, and so that's the Spanish RCT that just came out that showed that actually PAE came out a little bit better than TERP, and then also the PAE versus sham study from Portugal. And I think, like Matt said, those are 2 pretty important studies and really add to the data. And I would go back to him and say, yeah, I know these guidelines came out, but like Matt said, they didn't look at these papers when they made the guidelines. And here's 2 additional papers. And so now we're up to 4 RCTs and this, as well as against TERP, and as well as this RCT versus against sham. And I would just say, I think people are reasonable. It may be that it's more of a CYA situation for them. Which, if it is, then that's a tough thing to overcome because we're all scared of that day in court when someone says you went against the guidelines and had a bad outcome. But I would at least appeal to him with the data that wasn't included in that.
I did. I sent him the Spanish one. I need to send the other one.
Yeah. Sorry. So let's go back to your other question now. Yeah. So what was that other question again?
It was basically, approaching this in the right way to get your urology colleagues to basically buy in, to be on board with this.
How to do it?
Basically, I mean, how would you approach it? What?
Yeah, so I mean, I can tell you what I did at our place, and I think this is the right way to go about it, is to basically, again, don't overstate the efficacy. Target who's a good patient. Another big way to get in the door is hematuria, because even the guidelines can't keep you from doing a hematuria case. So, I definitely pitch the hematuria, because Matt and I have had this conversation a bunch. There really isn't a competitive procedure on the urology side for hematuria, nor is there a solution that they're too thrilled about. So it's actually, you're actually doing them a service by doing a PAE and getting a patient out of the hospital if he's admitted for prostatic hematuria. So hematuria is a big entryway. And then the other thing I would say is, I was fortunate that they were open to me coming and giving talks. I gave a morning talk, and then just recently another grand rounds. And so, I think it's much easier to make an argument if you're given the platform that you can give a talk and show the evidence.
Yeah, and I will say that the Ari's point about giving talks has been really great for us, but also from a training point of view with our residents, because now all of our residents come through and are very familiar with PAE, and so when they go out into practice, they will likely be expecting to interact with IR on many things, but one of them including PAE.
Okay. Yeah, that's good advice. And Ari, your point about going for the patient with hematuria is well taken for me, because the urologists I work with here, I mean, their practices are offering basically the whole spectrum of minimally invasive surgical therapies. And so it's been kind of challenging to find where PAE is going to fit in. It's like, we have, what about huge prostates? It's like, well, we have aquablation. It's like, well, what about,
well, then you should do embolization before the aquablation.
There you go. That's your winner right there.
There you go. I like it. So one other question I have is your recommendations for managing self-referred patients. I know how you guys are doing it now, but for somebody who calls your department and wants an appointment for PAE, do they see Matt first, or do they come to you? How does that work?
Yeah, so it kind of depends where they live and what their urologic care history is. So if one thing I'm really staunch about is that I really want every patient to see a urologist and have a BPH workup before they come and see me.
Yeah.
It's really important to know that their lower urinary tract symptoms are secondary to bladder outlet obstruction from BPH. If they're not, then I'm not going to do any good for them. So it's important for that to happen. And then in addition, there's other little things, like sometimes they're going to need a little more of a prostate cancer workup, or they're going to need a cysto to make sure that the blood that they're having is from their prostate and not from a bladder lesion. So, that's one thing. So if they're seeing a urologist wherever they live, and sometimes they're coming from far away, then I'll just get their records from the urologist where they are. If they're local, and the funny thing is sometimes they tell me, and this isn't that uncommon, is they say, well, the urologist I'm seeing, I don't really feel comfortable going back to them if I have a PAE, because they were really down on it. And I think they won't give me, either they told me they won't treat me if I have it, or they won't be fair to me as far as care goes afterwards. So there have been several times, or more than several, that patients in our area have said that to me. And I said, well, I have great urologists I work with. In fact, there's one individual who I've partnered with ever since the beginning, and he knows PAE almost as well as I do. He's heard me give my talk, maybe 15 times. And he'd be glad to see you. And so that's happened several times, but I make sure everyone's seen a urologist ahead of time. And if they're not comfortable with their urologist and they're local, I will, refer them over to UNC Urology.
One more thing I wanted to address is how you guys have approached, especially on your end, Ari, marketing for this procedure. When I came to my current practice, I was the only one who had any experience doing this. And so my group's like, we want to start marketing for you. We want you to go on a radio show and talk about this. And I said, no. I said, I want to wait until I have kind of addressed this with my local urologist and let them know this is something I kind of want to do. How do you guys manage it? I guess you probably don't have to.
Yeah. Well, our best
I'm
marketing.
Embarrassed.
No, I have to say our best marketing has been word of mouth from previous patients. So there's several ways that patients find us. We have a pretty good web presence that we started back when we did our clinical trials and kind of grown since then. And I think as far as search engine optimization, I haven't really done anything with that, but I think our site comes up pretty early when you search for PAE. And so a bunch of patients have found us that way. And then the other way that I hear about a lot is that there are these patient forums out there where, especially revolving around BPH, they seem to be really popular, where men talk about all the different possibilities and the really bad experience they had and the horrible doc they saw. I've had a few of those written about me, but they share their experiences. And so for the most part, I have to say, I've really tried to make the patient experience great. And I know, I have every confidence in Matt when he sees them that he's going to make them, he feel good about what they're choosing. So I've had a lot of patients post about their experience at UNC, and then a lot of patients send their friends. The most common situation is they're out with their golf foursome and they say, I had my PAE done in UNC. And they said, what's PAE? And they go from there. And then the next thing I know, I got a call or two from the other guys in the foursome to have a PAE done.
Yeah, I'd say from my experience too, I think word of mouth has been one of the biggest drivers of growth, at least at UNC. But I think I think our group is very fair about how we offer different options for BPH, and PAE is right up there. I think any of my partners, when they're discussing intervention for BPH, PAE comes up.
Okay. Guys, what else am I missing here that I haven't covered that you think is important to discuss in terms of building these practices together?
So from my point of view, I would say the argument about sort of self-marketing PAE is an interesting one, and I think a good one. I mean, I think there are urologists and urology practices out there who are going to be very maybe challenging to work with in promoting PAE. And so, hearing the argument about direct to consumer marketing for PAE is an interesting one. And, from the urology perspective, I don't know, maybe I would feel a little angry about it, perhaps, because I feel like
reasonably, I think.
PAH, but, from the flip side, from the IR perspective, if you have a difficult to work with group, I think that is an option, maybe just not the best option initially.
Yeah. Well, and I think it would make it kind of challenging too. If I start doing that and then I get this patient who calls my clinic and wants to see me, it makes it harder, I think, for me to then call the urology group. And I was like, but can you still see him anyway? I think it kind of puts a wrench in the whole collaborative manner of doing this.
Definitely. I mean, I think the collaboration is the way to go. And I think with time, it's going to become, second nature, honestly.
Okay.
Yeah. I mean, I think, Mike, if you make every attempt to collaborate and you're just not getting, that there's no sense of collegiality, or you're just getting blocked each time you try, I mean, what are you supposed to do? You're supposed to just drop it altogether? So, I mean, I understand. I mean, I think I think as long as you try first and make every effort to say, I want to work with you guys, I think this could be beneficial to us both for these reasons. And that's another thing. Maybe we need to talk a little bit more about that, because Matt mentioned it early on when in this podcast. But there is a financial positive potentially for you doing PAE for patients. There's a group of patients that may do PAE that might not do any other procedure. Right. And there's going to be more evaluations and potential procedures, smaller procedures associated with PAE, such as transrectal ultrasound or cystoscopy, that the urology group is going to perform, that's going to bring in revenue for them. So, I mean, I think it may be one thing if they don't want to refer any of their patients to you, but as long as you're, I don't think they have any right to be angry so much if you've made every effort and you've made the arguments of why it could be positive for both of you. And then I think you still have to try to refer those patients or send those patients back for evaluation for them to show that you're, even if they're not going to play with you, as you're going to play with them. You're going to be here. You're here to be a team player and to do what's best for the patients. And hopefully that takes after a while. And like our story, even our story with Matt, someone was angry in the beginning, right? So
you deserved it. It sounds like
it wasn't me.
Yeah. No, and that was more of a hypothetical for me. I have this challenge is a lot more natural. The group here they're really good. They've been very receptive. We haven't really gotten that far with it yet, but I've only been here a few months. What else, guys? Anything else I failed to cover?
One last thing is, from the urology perspective, and maybe it's because I have a guilty conscience, but I mean, we rely on IR for a lot of different things. And I think having that collaborative relationship is really important. And, PAE is just a small piece of that, right? But at the end of the day, it's what's best for the patient. And that's the goal.
No, I think you're right. I totally agree. This is just, our specialties work uniquely well and closely together because a lot of what we do kind of overlaps. But I think that we both have things that we can offer that it's just easier to do when we do them in collaboration. And so, that's why I think it's so important, not just for me, but for anybody trying to do this, go about this appropriately. It shouldn't be a competition because these are people that we work with, all over the place in the hospital.
Absolutely. One more thing I think we didn't kind of comment on was, and I think it's really important when you're thinking about building your program, is that it's really, like you were saying, Mike, when you were talking about the textbook we made, I think it's really vital that if an IR is going to start doing PAE, that he really takes the time to learn about the disease.
Yeah.
And that was the reason I wanted to put all those, the textbook starts with 4 urology chapters. It's straight urology. Matt edited all of them. And that was the reason I wanted to put those in the book first. I know that people buying the book are going to be rearing to look at the anatomy pictures in the back and the atlas and look at the technique chapter and all that. But it's super important to learn about the disease and be able to converse with the urologist in an educated way so that they know you're not just messing around, like you're not just dabbling in this. This is something you're serious about, and that you understand what the alternatives are and you understand why PAE might pose an advantage. For example, and what you were saying, I kind of cringed when you said it, when you talked about the really large patients undergoing aquablation, like why that potentially could lead to hemorrhage in the current state of aquablation, and why PAE might be helpful, even, like Matt said, in conjunction with potentially more as a replacement. But if the ins and outs of the other procedures and why they're and when they're indicated, it's a lot better to make a convincing argument to a urologist that you're doing this for the right reasons for the patient.
Right on. Well, guys, thank you both for taking the time to do this on a Sunday. I'm grateful for your time and your perspective. Anything else you want to hear?
Can you rap for us?
Please no. Please no.
No, I can't do it.
No.
All right, guys. Well, thank you.
Great,
Really
Michael. Thank you.
appreciate it.
Can you take us out with the BackTable rap?
Yeah, totally.
BackTable. Aaron, Chris, and Mike on the BackTable. The best in podcasts like Larry King is the cable. Legends in the biz like Aesop was the fable. Spewing vascular pearls like only they're able. IRIC, vascular, all in one. Coming together in the lab to get the job done. Minimally invasive, therapeutic, and creative. Q2 podcast with content clearly stated. Worldwide, global reach. They practice what they preach. International guests with wisdom to teach. So subscribe now, you know just what to do. Or else you might get Twitter climbed by Dr. Bob Ryu.